Hello, I'm Dr. Christopher Thompson from Boston, Massachusetts, and I'd like to thank Drs. David Haas and Millie Long for the kind invitation to participate in this year's postgraduate education course. My topic is POEM and ESD, and we will use a case-based approach. We will start by discussing endoscopic myotomies to treat esophageal diverticula, achalasia, and gastroparesis, and then move on to endoscopic submucosal dissection techniques, briefly touching on submucosal tunneled endoscopic resection and endoscopic full thickness resection. And throughout, we'll be discussing new technologies and interesting cases. And we'll start with a case. Here we have an 89-year-old female presenting with a 2-year history of worsening dysphagia. Her symptoms are more common with solid foods, particularly meats and bread. She also knows regurgitation and a 5-kilogram weight loss, and admits to some coughing with meals, but denies history of aspiration pneumonia or retrosternal pain, and her symptoms occur on a daily basis. And one condition you'd certainly be considering in this patient would be an esophageal diverticula. Zenker's diverticula was first described in 1769, and the first surgical treatment was in 1877. It's a herniation of the esophageal mucosa posteriorly between the cricopharyngeal muscle and the inferior constrictor muscles. It's lined with stratified squamous epithelium and has a thin lamina propria, but no muscle layer. Symptoms are what you'd expect: dysphagia, special maneuvers for swallowing, regurgitation hours after eating, coughing, bad breath, and borborygmy of the neck. And complications include aspiration pneumonia, esophageal obstruction, major bleeding from the mucosa, and fistula to the trachea or vessels. The diagnosis is typically made on upper GI series, as seen here, or on a modified barium swallow with video fluoroscopy, and the diverticula is located posterior and inferior to the larynx and adjacent to the esophagus. Upper endoscopy is helpful to assess the diverticula for potential treatment options. Staging can be done with the Leahy system, which is symptom-based, 1 being no symptoms, 2 dysphagia and regurgitation, and 3 esophageal obstruction, or the Morton system, which is size-based, small being less than 2 centimeters, intermediate 2 to 4 centimeters, and large greater than 4 centimeters. And again, on physical exam, you can see a bulge at the side of the neck, but the diverticula is truly emerging posterior, and that's a very important distinction to make. It's important for us to understand this anatomy and to be able to distinguish between the various types of esophageal diverticula. So here's the posterior view of the larynx, and you can see here the cricopharyngeal muscle, and below we have the outer longitudinal fibers of the esophagus and the circular fibers here, and the inferior constrictor, kind of part of this complex here. And you can see the diverticula can emerge from various areas. So kind of laterally here, you'd have a Killian-Jamison diverticula, right along where the recurrent laryngeal nerve is. And we have Zenker's kind of coming out above that cricopharyngeus. Here's another look at this, where the Killian-Jamison would be emerging in this tunnel here, right along that recurrent laryngeal nerve and right next to the trachea, whereas the Zenker's is coming out over this area. Another way to look at this, so the Zenker's coming out above the cricopharyngeus, the Killian-Jamison coming out laterally, perhaps better seen here, and then the Lamer's diverticula is coming out posterior and inferior to the cricopharyngeus, so just below the Zenker's. This is what it would look like on an upper GI series. The Zenker's is posterior and above the cricopharyngeus. Killian-Jamison is lateral, okay, right along that trachea, and the Lamer's is distal to the Zenker's below the cricopharyngeus. And here we see a Zenker's diverticula and Lamer's diverticula in the same patient. It's also important to distinguish between the various types of diverticula you may see in the more distal esophagus, including the epiphrenic diverticula seen here, which tends to be a Poljan type of diverticula, just like the ones we've been discussing, where you have a herniation of mucosa and submucosa due to increased pressure in the lumen of the esophagus, versus a traction type diverticula, which you may see more in the mid-esophagus, corresponding to the subcarinal lymph nodes. And this is due to a pulling, traction on the esophageal wall, so the entire wall is herniating here, and due to these chronic inflammatory processes. And these are obviously much more difficult to treat endoscopically, and something you should be mindful of. There are a few treatment options for these proximal diverticula, including open surgery or a transcervical diverticulectomy with cricopharyngeal myotomy, rigid ENT approach using a stapler or a laser, and then the flexible endoscopic approach. Here we see the open transcervical approach, and they're dissecting out the diverticula, and then they'll staple across the neck of it and put a drain in there and close. And then the rigid ENT approach is seen here with a stapler. You have to kind of hyperextend the neck to get the stapler in position. And here are some examples of an endoscopic approach. On the left, we're using an insulated tip knife. And on the right, we're using a pair of electrocautery enhanced scissors. And you basically just trace down the septum to the bottom of the diverticula. And it's very straightforward. However, it's critically important you know what type of diverticula you're dealing with, because this is not necessarily safe in all types, such as Achilles-Jamison, where you have that recurrent laryngeal nerve and other structures. This is very different than the Z-poem technique, which involves tunneling. This is a meta-analysis that looked at 20 studies and over 800 patients using a similar endoscopic approach to what I've shown. And you can see that 23% of these patients roughly had undergone some previous attempt of some form of therapy. Success rates 91%, adverse event rates 11.3%, nothing life-threatening there, and recurrence rate of about 11%. So it's quite a well-established and good technique. Back to our case. Here's our 89-year-old female presenting with a 2-year history of worsening dysphagia. So you can see here the modified barium swallow. See some kind of collection in here. And here's a still from an upper GI. Diverticula kind of coming off right here. And here's a head and neck CT. So it looks quite lateral. And so what is the most likely diagnosis? A, a Zenker's, B, an epiphrenic diverticula, C, Achilles-Jamison, or D, a Lamer's diverticula. And that is very lateral in position, so we can say this is most likely Achilles-Jamison. And then what is the next best step? Standard endoscopic myotomy, a stapled diverticulotomy, a Z-poem, or an open surgical approach. So probably either a Z-poem or an open surgical approach. You'd want to avoid either of those more common myotomies that we perform, as you could really clip that nerve, as you see here. And this is a Z-poem technique we performed. And you can see we kind of open it up. We go a little deeper in the tunnel, and we can see, potentially a nerve right there. Moving back down the esophagus, we have achalasia. The entity was first described by Sir Thomas Willis in 1672, and Ernst Heller performed the first surgical myotomy in 1913. Achalasia is Greek for does not relax, and it's characterized by diminished or absent peristalsis with failure of lower esophageal sphincter relaxation. Pathophysiology involves loss of ganglion cells within the myenteric plexus, Auerbach's plexus right here between the longitudinal and circular fibers, and loss of inhibitory nitric oxide ganglion function, resulting in impaired relaxation with relatively intact cholinergics. The diagnosis is often suggested on upper GI series, and here we have some classic upper GIs. This is a bird beak esophagus with a relatively dilated esophageal body, perhaps a long high pressure zone here. You can see that in maybe type 3 achalasia. A sigmoid esophagus as it progresses and gets even more dilated here. And then maybe an example of spastic achalasia. However, the diagnosis is not made in upper GI. It's made on high-resolution manometry. And what's consistent across all the different types of achalasia is impaired lower esophageal sphincter relaxation and absence of peristalsis. Now here we have type 1 achalasia in the middle. And what's unique here is there's a very low esophageal pressure throughout the body with pressures less than 30 millimeters of mercury. In type 2 achalasia, we have panesophageal pressurization, where the pressures are greater than 30 millimeters of mercury. And in type 3 achalasia, we have distal esophageal spasms. The Eckardt score is a symptom score that's helpful for tracking progress of patients, and it includes weight loss, dysphagia, retrosternal pain, and regurgitation. And a score of less than 3 is considered normal, and a score of 9 suggests the patients might not respond as well to POEM. Functional luminal imaging probes can also be helpful in establishing the diagnosis. And the first thing you look at is the distensibility index. If the EGJ distensibility is less than 2.8, that's abnormal. And then you'll look at the distension-induced contractility pattern. You can have repetitive retrograde contractions or repetitive antegrade contractions, or neither. And then you use this information to come up with the flip panometry classification. And REO stands for reduced esophagogastric outlet. And if you have a low distensibility index, you will likely have an REO, and then you'll be looking at the contractility patterns to make further distinctions. So here we have a low distensibility index, so low DI, and there's no contractility, no peristalsis. So this is something you'd see with type 1 or type 2 achalasia. Here we even have a lower DI. It's rather dramatic. No peristalsis, but some pressure in here, and this is probably consistent with a type 3 achalasia. And here we have a reduced DI, but we do seem to have some repetitive anti-gate contractions. So this is perhaps more in keeping with an EGJ outflow obstruction. This animation highlights the basic steps in the typical EPOEM technique. We begin with a submucosal injection and access into the submucosal space. And then we create a tunnel roughly 10 to 12 centimeters in length, extending at least 2 centimeters beyond the lower esophageal sphincter. This is then confirmed endoscopically. The myotomy has begun roughly 2 to 3 centimeters distal to the access site and extends again roughly 2 centimeters distal to the LES. And the access site is then closed with clips. This is a table from a review looking at long-term outcomes from POEM, and you can see there's a relatively good number of patients here with follow-up ranging from 12 to 36 months. Clinical success typically in the 90s to 100% here, with one a little lower. Eckhart scores tend to improve below 3 across the board. LES pressures also improve rather considerably. And the one thing to watch out for here is GERD, which clinical GERD seems to appear in the high teens to low 20% range. Here we have a randomized controlled trial comparing EPOEM to balloon. And you can see there's 67 to 66 patients randomized to either POEM or sequential balloon dilation up to a 35 millimeter balloon. Main outcome here was treatment success defined as an Eckhart score less than 3 at 2 years of follow-up, and absence of a severe complication or need for retreatment. So our results here, 92% of the patients in the POEM arm were considered successful versus only 54% in the pneumatic dilation arm, and that was significant. You can see in this figure here on the y-axis you have Eckhart score, beginning and end, and each one of these lines represents a patient. This is the POEM group, and this is the pneumatic dilation group. And you can see this darker bluish color represents treatment success, and yellow is treatment failure, and blue is complication. There was a complication here in the pneumatic dilation group. And the other thing to note here is that GERD was more frequent in POEM. So how does EPOEM compare to laparoscopic Heller myotomy? Well, this meta-analysis asked just that question. It included 74 studies with over 7,700 patients. Over 5,800 patients had undergone laparoscopic Heller, and over 1,900 patients had undergone POEM. The follow-up period did differ significantly between these groups, that's worth noting, shorter for the POEM group. Overall success was higher in the POEM group at 93% versus 88%, and the predicted probabilities for success at both 12 and 24 months also significantly favored POEM. However, GERD symptoms were also higher in the POEM group at 18.5% versus 17.5%, and the odds of GERD on pH monitoring were also roughly 4 times higher in the POEM group. There are no universally accepted algorithms. However, this is one that is commonly followed. If someone has dysphagia, you perform an upper endoscopy to exclude strictures or cancer, and then high-resolution manometry, and you're looking for a high IRP. And if they have EGJ outflow obstruction, you want to investigate for opioid-induced achalasia. And then you can do a timed barium swallow to assess for obstruction and look at an Eckhart score here. If it's greater than 3 and they're low surgical risk, they can either have the balloon dilation, Heller, or POEM. And if they're a bad surgical risk, then you can consider Botox. If they do have end-stage achalasia, you'd be considering esophagectomy at this point. On to another case. Here we have a 66-year-old male with dilated cardiomyopathy with an EF of 20%, requiring a permanent pacemaker and AICD. He presents with progressive dysphagia and regurgitation, but denies retrosternal pain. He also describes frequent coughing fits and is unable to take cardiac medications or tolerate oral secretions. He has a 14-pound weight loss and was recently placed on TPN. Here is his timed barium swallow. You can see at 5 minutes, there's a rather long column length, and also you see some spasms here in the distal esophagus. Here is the flip. You see a relatively low DI, and there's no peristalsis or any contractions. And here is the high resolution manometry. So here we have a high resting distal esophageal pressure here, and there's no peristalsis. So what's the diagnosis? A, type 1 achalasia, B, type 2, C, type 3, or EGJ outflow obstruction. Well, that's pretty straightforward. It's most likely type 1 achalasia with the low pressures in here. What's the next best step? So he's quite sick. What what would we offer here? The surgeons don't want to do a Heller. Emetic balloon. Well, we do an EPOM. He can't handle oral secretion, so a PEG is not going to be effective. He's too sick for a Heller. And one thing to consider here is the use of monopolar devices versus bipolar. So this is a bipolar device. It uses microwave for vessel sealing and RF to caught. And this is advantageous here, so you wouldn't have to turn off the pacer, or the AICD. Moving on to gastroparesis and GPOM. Gastroparesis is, of course, often a chronic condition that's characterized by delayed gastric emptying and affects up to 4% of the population. Etiologies of chronic gastroparesis include diabetes, post-surgical, and idiopathic. And the mechanisms here are either alteration in gastric motility or increase in pyloric tone. And the GPOM technique, very similar to what we showed you for EPOM. Again, you're creating a tunnel, performing a myotomy, and closing the tunnel. The body of literature around GPOM is, of course, less robust. However, we do have this meta-analysis of 10 studies with 281 patients that shows a significant improvement in the gastroparesis cardinal symptom index score here, as well as a significant improvement in 4-hour gastric emptying scintigraphy. However, the quality of evidence via the grade methodology was of low certainty for the GCSI and very low certainty for the GES. And now we'll quickly cover some ESD techniques and outcomes. And this is our last case. A 74-year-old male referred with a recurrent polyp in a descending colon after an EMR was attempted 6 months prior. The pathology is tubulovillous with low-grade dysplasia and a positive lateral margin. A repeat EMR was attempted on the follow-up procedure. However, the lesion did not lift. The lesion was estimated to be roughly 10 millimeters in diameter and appeared flat, and the patient's in otherwise good health. ESD was pioneered in Japan for the treatment of early gastric cancer and was formally defined in 2003. There are multiple techniques that are still evolving, and there are also numerous classification systems, including the TNM classification, and then, of course, we have whether or not a lesion is pedunculated, protruding, or depressed, and Kudo classification, NICE classification, so many different systems that are beyond the scope of this talk. Here are two of the most common techniques. The traditional ESD technique on the left, and what would be a pocket ESD on the right, but this is really a stir. So on the left, we're marking, we're then lifting, and then we're making a circular incision and dissecting. And on the right, we're injecting, creating a pocket, and then we're tunneling down and dissecting out this lesion, and then we'll remove it. So this is submucosal tunneled endoscopic resection for lesions that are beneath the mucosa in the submucosal space. But similar to what you do for a pocket ESD of a mucosal lesion. This meta-analysis looked at gastric ESD versus surgery and included 18 studies with nearly 6,000 patients and found that ESD was associated with a lower risk of procedure-related death and overall complications. However, it was also associated with lower rates of curative resection, higher rates of local recurrence, and lower disease-free survival rate. This meta-analysis compared colonic ESD to EMR and included over 281,000 total colon lesions. And the results showed that ESD had a higher rate of en-bloc resection and complete resection. ESD also had less positive lateral margins and less recurrence. Perforation was higher in ESD and procedure time was also longer, no difference in bleeding, and no difference on sensitivity analysis for lesion size. Authors concluded that ESD should no longer be restricted to lesions greater than 20 millimeters. What about hybrid ESD? So this is a modified technique where you still inject a cushion of fluid under the lesion and make your circumferential incision. However, instead of doing the formal dissection here, you would snare the lesion off and seal some vessels. So this is a meta-analysis looking at 16 studies over 700 patients, and they found the rate of en-bloc resection was over 81%, complication rate 7.7%, and the need for surgery at 4.52%. The subgroup analysis comparing ESD to hybrid ESD found that hybrid ESD took less time and with lower complications, and hybrid ESD also had a lower rate of en-bloc resection. There was no difference in rates of recurrence or the need for surgery. And finally, we have EFTR, or endoscopic full thickness resection. And here you see we're using a device for this. It's a cap-mounted clip. You can still mark the lesion and then pull this lesion into the cap, and then the clip is released, and you snare off the lesion and release a band as well for security. So this is the FTRD device in a meta-analysis looking at 18 studies over 700 patients. And indications here were really difficult residual colorectal adenomas for the most part, or something challenging about the case. And results, median size was 13.5 millimeters. There were 22 failed attempts at using this device. Pooled overall R0 resection rate was 82%. 110 patients, or 7%, underwent surgery for some reason. And here we have the pooled rates for post-EFTR surgery due to invasive cancer or non-curative resection at 4%. Back to our case of that 74-year-old male with the failed EMR and a residual lesion that will not lift now. What's the next best step? Repeat EMR, ESD, EFTR, or surgical resection? This is tricky and, of course, is dependent on what you have available, but we would probably go with the FTR in this case. In conclusion, endoscopic myotomy and resection have proven safety and efficacy, and for many centers, these advanced techniques have become standard of care. Certainly some questions do remain regarding optimal technique and long-term outcomes, and the learning curve is challenging, but new technology is helping. Thank you for your attention.